Please listen carefully.
Hello and welcome to GasGasGas, your one-stop podcast for the FRCA Primary Exam. This podcast will fill your brain with information. Listen to it, think about it, and check out the show notes on the website. There you will find the core diagrams you need to be able to draw and describe for the exam. This podcast can squeeze into your day. Listen while you're driving to work, cooking dinner, maybe when you're on call, or in the gym. Eventually the revision is going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Remember to rate and follow the show to hear much more. Hello, my fellow GasGasGas co-conspirators. My name's James, and today we're looking at the primary FRCA exam content you need to know for morphine. We're talking morphine itself and the opiate receptors, exploring the mechanisms by which morphine works, its pharmacokinetics and pharmacodynamics, as well as a bit of a look at clinical use. Now, I appreciate everyone is very familiar with morphine, and this serves two issues up. One, the examiners are going to expect you to know more than the average doctor by a fair bit, given its ubiquitous use and daily use in anaesthesia. And the counter to this is that this topic might feel really boring because you're already very familiar with this drug. So, I've gotten carried away, and I've been on the hunt for some cool facts about morphine. Just to get things started. Fact 1. Friedrich Saturner, he's a German pharmacist, isolated morphine from opium poppy resin after fiddling around in his lab for quite some time in 1803. He named it morphine, after the Greek god of sleep and dreams, so-called Morpheus. I now realise this is why, in The Matrix, Morpheus is called Morpheus, because he presides over fishing people out of the Matrix adult dream state. And what you would naturally expect of a scientist trying to elucidate such things, he tested it all on himself as well. Much like the structure for the last podcast, we're going to pile straight into some questions and answers. Hello, Doctor, this is your Pharmacology Viva. Where are the opiate receptors found, and how do they exert their actions? Yes, opiate receptors are ubiquitous throughout most of the central nervous system, and they're also found in the enteric nervous system. There are several subtypes of opiate receptors. These are called the mu opiate receptor, MOP, the delta opiate receptor, DOT, the kappa opiate receptor, COP, and the nociceptin receptor, NOP. The mechanism of action by which morphine exerts its effect is one of agonizing the G-protein coupled inhibitory complex that is associated with these morphine receptor subtypes. G-proteins have those 7 transmembrane domains which communicate with an intracellular secondary messenger system. Upon agonizing the opiate receptor in question, these secondary messenger systems cause potassium efflux in the neuron, leading to cellular hyperpolarization. They induce closure of voltage-gated calcium channels, making it harder for the cell to depolarize again, and inhibit adenyl cyclase activity, leading to reductions in cyclic AMP. Cyclic AMP is thought to modulate glutamate sensitivity. The sum of all these actions is that the neuron becomes less excitable and therefore less able to transmit pain signals from peripheries to the central nervous system and cortex. Yes, and what agonists are you aware of that act upon these opiate receptors? There are many agonists of opiate receptors. The ones that chiefly jump to mind would be morphine, fentanyl, and alfentanil, very commonly used in anesthesia. Other drugs that have activity would include pethidine, methadone, buprenorphine, and diacetylmorphine, or diamorphine. One other drug that comes to mind that does have a degree of mu-opiate receptor activity is ketamine, although its chief action's elsewhere. Yes, moving on. There are a number of key areas within the central nervous system that opiates act. Tell me more about this, please. The 2 places that come to mind are presynaptically in the dorsal horn of the spinal cord. Agonized opiate receptors here inhibit the activity of spinal A delta and C nerve fibers from transmitting pain peripherally to centrally. The second chief area is in the periaqueductal grey matter. This is an area of the midbrain involved in nociceptive transmission. Morphine or other opiates here act to modulate the activity of a descending inhibitory control pathway for pain that again modulates spinal cord transmission. Of note here, guys, opiate receptors are obviously also found in your GI tract. That's why you get constipated, and in your cortex particularly, where it makes you feel great apparently, depending on who you talk to. So, fact number 2, in 1874, diacetylmorphine was discovered, and it was touted as a cure for morphine addiction. Diacetylmorphine, as we all know, is heroin, and you can see the irony here. This situation sounds very familiar, because OxyContin was not meant to be addictive either. So we're going to talk a little bit more about morphine receptor subtypes. So we mentioned MOP, COP, DOP, and NOP. These are the 4 that you should know about. So-called for a agonist that was originally discovered that bound to them. So MOP, mu, the prototypical agonist was morphine. COP, kappa, opiate receptor, was originally found to bind to ketocyclazine, never heard of that one before, and DOP because it was found in the vas deferens of mice, as you do. And NOP, so-called because of nociceptin. This is a neurotransmitter that increases your pain sensitivity. Others do exist, and for interest, there's something called ZOP, or the zeta, depending on how you pronounce it, opioid growth factor receptor. This is stimulated by MET5 enkephalin, and it regulates tissue growth and development in normal and tumorigenic, i.e. cancerous, tissues. Interesting. So now we're going to do the exceedingly dry bit here and talk about the data for morphine and that nice blurb that you should be able to barf out if required, although more commonly you'll probably find yourself talking about components of what we're going to discuss next. So, morphine is an opioid, i.e. a synthetic opiate, because they synthesize it these days instead of trying to fish it out of poppy seeds. It's a clear, colourless liquid and can be prepared as a tablet, an oral liquid, a patch, an IV preparation, preservative-free intrathecal preparations can be administered intranasally. The concentration varies considerably, but you will classically find 10 mg and 15 mg ampules for IV use in theatres and ampules with 1 mg in for intrathecal use in theatre. Its dose range is 0.1 to 0.2 mg per kilo, although naturally you can give more. Intrathecally, the range is from 200 to 1000 micrograms. The common dose is 200 to 300. Its mechanism is opioid receptor agonism, leading to damped neuronal firing in pain pathways and a reduction of neuronal excitability. If given intramuscularly, it has a 30 to 60 minute time delay for peak effect. Intravenous administration, the range is quoted as 15 to 30 minutes. It seems to take a while. Most people just experience that dizziness and feeling a bit woozy first, instead of actual pain relief. It lasts 3 to 4 hours. It does have a relatively forgiving side effect profile. Breaking it down systematically, it'll look good in the exam. Cardiovascular side effects, very stable, but in large doses may cause a bradycardia, and it reduces systemic vascular resistance, which is often more demonstrable in a orthostatic hypotension variety as opposed to just a patient becomes hypotensive perspective. The respiratory system is affected by morphine. It causes respiratory depression, reduces your sensitivity to plasma CO2, and has a potent antitussive, i.e. cough inhibiting effect. There is a dose-related delayed respiratory depression effect when morphine is given intrathecally. The range of effect is 2.5 to 12 hours. Peak is at 6 hours. That's useful knowledge just for daily practice there, guys. GI-wise, it makes you feel sick, it makes you get constipated, and you reduce GI motility. CNS-wise, naturally, it causes analgesia, euphoria, and anxiolysis, so it makes people feel a bit chilled out too. And considering their eyes, causes miosis, small pupils. Metabolically, people can get a bit itchy, especially intrathecal morphine. This is intrathecally not modulated by histamine, but it also can trigger histamine release when given IV. Sometimes you can see a bright red tract up the patient's arm as it tootles along. It also increases ADH secretion, i.e. your patients who are now secreting more antidiuretic hormone, hold on to water and get all dilute, and they could get a little bit of relative hyponatremia. Oh golly, morphine times. So, fact number 3. This is a good one. So, Sir William Osler's pal and surgical behemoth, William Halstead, was initially addicted to cocaine when he was at work. He went on, after several bouts at rehab, to swap this for a good old-fashioned morphine addiction. Osler and Halstead were 2 of the 4 founders of Johns Hopkins University hospitals in the United States. Halstead is famous for probably inventing surgical gloves, transfusing his own blood into his postpartum hemorrhaging wife, and whipping out the gallstones from his mother at 2 o'clock in the morning on a kitchen table. Cool. That was your 3rd fact. What could possibly follow that? Moving on to the pharmacokinetics of morphine. So, absorption, it's 15 to 50% orally bioavailable, and there is significant hepatic first-pass metabolism. This is why oral morph is nowhere near as potent as IV morphine. Distribution-wise, it has a pKa of 8, so it is 23% unionized at plasma pH. It's 20 to 40% protein-bound, and has a volume of distribution of 3.3 to 4.7 litres per kilo. Call it 4 litres per kilo. Morphine metabolism. Phase 1, there is scant N-demethylation to normorphine, but this is more or less negligible. Mostly morphine is phase 2 metabolized via glucuronidation, and I'm sure you've heard of morphine 3 and morphine 6 glucuronide as the metabolites. So these are almost entirely cleared renally, 90%, some say 70% renally cleared, with the rest going out through your biliary system. There is some enterohepatic recycling of that biliary bit, because glucuronidated things can get easily hydrolyzed by the bugs in your GI tract, and then you can reabsorb them. Cheers, bugs. So morphine 3 glucuronide makes you drowsy, and 90% of morphine is converted to that. 10% of morphine is converted to morphine 6 glucuronide. This is an incredibly potent analgesic, 13 times more potent than morphine, and that's renally cleared too. Morphine is renally cleared at a rate of 12 to 23 mils per kilo per minute, and its terminal half-life is 2 to 4 hours. Lots of information there. Lastly, we're just going to look at these morphine receptors in a bit more detail. Probably more likely to come up in the SBA than someone mercilessly quizzing you in the Viva, but who knows? So, the MOP, or mu opiate receptor, has a natural ligand, which are the endorphins mostly, with a bit of enkephalin and dimorphine also agonizing it quite happily. The mu opiate receptor is mostly associated with analgesia, respiratory depression, constipation, and the cardiovascular effects. This is probably why REMI, which is very mu opiate receptor happy, causes that drop in heart rate and drop in cardiac output that you see, knocking about 20% off your cardiac output. Your COP, or your kappa receptor, again, is agonized by endorphins and dynorphin mostly, quite potently in fact. Again, COP is associated with analgesia, but it is less of a respiratory depression offender. Your DOP, your delta, or your vas deferens of a mouse receptor, is also good mates with the endorphins and enkephalins, and plays a role in mood and movement. And then your good old-fashioned NOP, this is your nociceptin receptor. The natural ligand for this one is nociceptin, but also this thing called orphanin, God knows. In low doses, nociceptin causes hyperalgesia, but in high doses, it causes analgesia. Cool. We're going to close out with one more opium fact, and this is a bit more geopolitical. So the Opium Wars, in a nutshell, as far as I understand it, the British were profiting from illegally importing opium from India into China. They were naturally profiting from that. China was not amused, for 2 reasons perhaps. As their population was becoming rather feckless as they were all addled on opium, things weren't going so well for them, but also it led to a negative trade deficit, which is bad for their economy. So, China blockaded and confiscated what they could. Britain, not amused by this, initially sought to negotiate their way out of it, but eventually gave up, captured territory, destroyed the blockades, and subsequently forced concessions from China, given the British military superiority at the time. That was the first Opium War. There was a second one. Ultimately, there was some obstruction from China in opium trade, and the Brits went straight, seemingly, to a military conflict But the French joined in this time on the premise of the Chinese killing a diplomat or something the year before. The Second Opium War led to the capture of Beijing. There was a palace in Beijing that got sacked, and further Chinese concessions occurred. Bad times for them. So, hopefully you've learnt a bit about morphine, but also it wasn't too disastrously boring. There are a couple of take-home points. It is a ubiquitous drug used daily by many anaesthetists, and a good understanding of its uses and clinical effects is essential. When you're using it intrathecally, the respiratory depression tends to occur from 3.5 to 12 hours with a 6-hour peak. So at 12 hours, if someone's in gibbering agony, you can feel a bit happier with giving them some parenteral morphine-like substances. It's important to remember that morphine 6-glucuronide, whilst there's not much of it that's converted from morphine to that in your liver, is 13 times as potent and is renally cleared. So people with CKD plus morphine, sketchy combination. Another thought here is that codeine is eventually converted to morphine and then is eventually converted to morphine 6-glucuronide. So in someone with really bad renal disease, be thoughtful with codeine too. I have had a patient opiate toxic from codeine use only. Fentanyl is probably better than morphine. The only advantage with morphine is it lasts longer. There is a kinder side effect profile with fentanyl. And the humdinger, last one, don't mix up your 10mg IV morphine with your 1mg ampule of intrathecal morphine. It definitely happens because they look exactly the same. My final fact is that the likelihood of there existing a non-addicting opiate, given the fact that the receptors are naturally liganded by endorphins, seems unlikely. But the Sackler family and Purdue Pharma did some excellent marketing and profited quite a bit from suggesting that Oxycontin, did otherwise. This entirely failed to go to plan on their part, and the Sackler family estate agreed to cough up $6 billion to make all the lawsuits in America for opiate addiction go away. Clearly, their antitussives didn't work for them. Ha! Anyway, you've been listening to James. This is GasGasGas. Cheers for listening. If you found it useful or awful, please like and subscribe and rate the show. Definitely check out the show notes for those diagrams and the detail of this content. It is a bucket of content to get to grips with. Keep working at it, and you will get better, faster, and stronger. It is vital to keep your interest live for the science that we're covering and not overcook yourself. You will be amazed by what you know come exam day. Don't freak out. Keep studying.